I'll be speaking about a case where we had a vertical shear fracture and of the hemipelvis with a sacral fracture, and we have done a triangular fixation. So coming to this case, this is a 35-year-old male who had met with a road accident where he is a farmer by occupation and had topple of a tractor in which he was traveling. So he sustained injury to the pelvis, his chest, and a humerus fracture. Initially, he was unstable hemodynamically. He was managed with a pelvic binder and traction and chest tube and multiple transfusions in the center, initial primary center. Once he had become stable, he was referred, and what we found was he was clinically stable, and but he had a foot drop on his left side. So we went ahead and did a CT scan to see how it is, and we found that the left hemipelvis, along with this part of the sacrum, is totally disrupted and away from the rest of the remaining sacrum and the spine. So this is what is called as a spinopelvic dissociation. So what if you took a look at the inlet and outlet view, you will appreciate that the left hemipelvis is prone for multi-direction in all three direction, different forces, and it is a very unstable fracture. So what was our aim of treating this fracture? Our aim is to restore the alignment between the ilium, sacrum, and the spine, and achieve stability of the hemipelvis to the spine. So how do we so that we have achieve stability both in translational and rotational stability in both in vertical and horizontal direction. What about the neurological? And we, because he has a foot drop, we have to think about decompressing the fracture also. So we plan for a triangular fixation. That what is you mean by triangular fixation? You have one component called as a lumbopelvic fixation, where you have we counter the vertically related forces, and then you have the horizontally countering a fixation, which is the SI screw. So if you look at the papers, among the different types of fixation, the triangular fixation has maximum stability. So it gives maximum axial stiffness, wherein there is very little movement at the fracture site and helps in union. So we plan for it. But before we do that, very important, you look at the back, the lumbar region, to look for any degloving. In our patient, we didn't have any degloving. At the same time, the patient has to be stable. We also look in detail about the CT scan. We have to look at the how the L5 S1 facet is, L5 pedicle, and L5 transverse process. In our case, we had a L5 transverse process fracture, but the pedicles were intact, so we can put a pedicle screw in L5. We also look into the part of sacral dysmorphism, as Dr. Vivek Trika had told, because that is how you will plan for putting your SI screw. And then we have to look into the intraforaminal bone fragments, because that if they are there, then we have to do a foraminotomy. We operated this case in a prone position. We have draped from whole of the lumbar region up to the natal cleft, then took a midline incision from L4 to S3. Our incision was there, and we subperiosteally elevated all the muscles so that the transverse process as well as the posterior superior iliac spine and posterior inferior iliac spine are visualized well. This is the technique we have used for reduction. We give longitudinal traction for vertical displacement, then we put it in extension for flexion deformity, then we internally rotate for external rotation deformity, and lateral displacement is reduced by a Weber clamp. Then we put the pedicle screws both in L5 and L5 and the L4, then the ilial screw, and then once we finish that, then it is when we put a iliosacral screw. This is the Once we have done that, finally we put the connecting rod between the ilium and the spine. This is the sequence of which we have to do. We'll talk about the iliac screw, but that is the most important point. Here, there's a cleft between the posterior superior iliac spine and the posterior inferior iliac spine. That should be your entry point. You should direct your entry from in a lateral position to the inferior position. Generally, the drill will find its way between the outer and the inner cortex, and your length should generally be between 80 to 100 ml, 100 mm, so that it has a purchase at two segments of the iliac corridor. In how do we know whether we have placed it in a correct position? You look into the iliac view and you see that it is directed at the anterior inferior iliac spine, and it should be above the sciatic notch. In an obturator outlet view, it should lie within the teardrop in this case. This is how these are the pedicle screws. This is the iliac screw, and it is connected with a connecting rod. We do not do a decompression here. We have just achieved accurate anatomical reduction of the sacral fracture that itself will cause a decompression of the nerve root in an indirect way. Then post-operative, you can see that these are the post-op x-rays, both in the inlet view and the outlet view. You can see a very good reduction of your sacrum, both in the inlet view and the outlet view. Generally, we ask them to walk partial weight immediately for the first 6 weeks. But in this case, we did not allow because he had a humerus fracture. And at end of 6 weeks, we made him walk full weight bearing. We found that at end of 12 weeks, almost we could see some haziness around the sacrum. And at end of 6 months, he had almost a near total complete recovery of the foot drop. We also recommended for removal of the lumbosacral, lumbopelvic implant removal, but I don't think he ever turned back again. These are the post-op pictures. You can see the incision, both the humerus and the spine. He's able to bend very well. And if you look at the video, he has really recovered foot drop with a very little residual part where he's not able to dorsiflex it to the maximum. So in conclusion, yes, sacral fractures where there is a spinopelvic dissociation, these are highly unstable fractures and are generally associated with neurological deficit. And management generally involves restoration of the hemipelvis to the spine, and this can be achieved by a triangular fixation. What does the triangular fixation provide? It provides absolute stability. So your fracture union is consistent. You can start early weight bearing, and secondary complications are generally less. In terms of nerve decompression, whether to decompress or not to decompress is debatable. Thank you very much.